It is my pleasure to introduce Dr. Amanda LaGreca. Dr. LaGreca is an endocrinologist and assistant professor of medicine at the University of Colorado School of Medicine in Aurora, Colorado. She received her medical degree from the University of Buenos Aires and completed her residency at Yale New Haven Medical Center in Connecticut. She did her Thyroid Cancer Fellowship at Memorial Sloan Kettering in New York City. For those of you who are joining us online, we encourage you to ask your questions via the Q&A tab. You can also raise your hand and we will unmute you and allow you to ask your question live. And for those of you in the room, please raise your hand and I will bring the mic to you. We're asking that you hold your questions until the end of Dr. LaGreca's presentation, where we will then open it up to both our Zoom room and our room here in Colorado. Thank you. And now, Dr. LaGreca.
Thank you so much for this kind introduction. Good afternoon, everyone. So I'm going to talk about the importance of lifetime follow-up on thyroid cancer. I did build my talk mainly on differentiated thyroid cancer, so papillary, follicular. This also applies for medullary thyroid cancer. So most of the things, and I have plenty of time in the second part of my talk for questions. So we're going to start now. Okay, I think okay, there you go. Okay, so we hear all the time, this is the good cancer, this is, the cancer to have, but I still want to remind the audience and that, in 2023, the estimated new thyroid cancer cases were about 43,700 cases and the deaths were about 2,100. So we're trying to become visible, especially for research and things that we have to develop on thyroid cancer and not be ignored as to have the good cancer. And I hope nobody uses that any longer. So if you have friends and family members, advocate for that we still need these to become visible so we are heard, and research funding are for physicians and PhDs to go and further discover therapies for people who are dealing with advanced thyroid cancer. So most of my practice is thyroid cancer. I do some days that I do biopsies, and I would say that the other 60% of my practice is about advanced thyroid cancer. So I see a lot of people with metastatic disease, and I give a lot of tyrosine kinase inhibitors, which are the metastatic population. So this one is to remind everyone that we still need a follow-up for life on thyroid cancer, even if you have what we call low-risk disease. So this is a study, a famous study that was published in JAMA in 2014 that showed the significant rise on the number of new thyroid cancer cases. And if you see the dotted line in the bottom, most of these new thyroid cancers were at expense of papillary thyroid carcinoma. So clearly there's more detection of small thyroid cancers. And then the community of physicians had to face with a lot of things that were low risk and needed attention, but not extreme measures. And we're gonna talk more about that on the following slide. So I'm gonna start with a case. This is a 32-year-old woman. She felt a lump on her left side of the neck. So typically, when I get this story, I'm very careful because usually these are cervical lymph node metastases. Lumps on the thyroid are rarely felt unless they're very big because of the position of the thyroid behind these strong sternocleidomastoid muscles. But when people become with palpable disease, it's usually already a disease that has spread to the lymph nodes on the neck. She consulted with her PCP. She was treated with antibiotics, very common. Anybody with this story, everybody's treated with some antibiotic before to see if that comes down. The neck nodule continues to enlarge, and then she had an ultrasound that shows a thyroid nodule and a cervical lymph node that was abnormal, and both on biopsy were positive for papillary thyroid carcinoma. So when we're talking about the new, the initial treatment of thyroid cancer, we have the old times where we used to do total thyroidectomy for everyone, followed by a high dose of radioactive iodine. We would suppress that TSH very, very low for a number of years. And then the patients would get these annual whole body scans. They would have to stop the thyroid hormone replacement and get all the screening. And now with more detection of those small papillary thyrocarcinomas that I show on one of the studies in 2014, then the approach is different and it's trying to be more individualized according to the patient needs. So now we're talking about partial or total thyroidectomy. We're talking about plus minus radioactive iodine. Are we giving no radioactive iodine and we're just going to observe? Are we going to give a low dose, and that's called ablation? Are we giving adjuvant therapy? And those are the high doses that are trying to kill additional microscopic foci of thyroid cancer. And then we're going to suppress the thyroid hormone at lower levels or less and less depending on the risk of recurrence of that tumor. The American Thyroid Association guidelines in 2015 became with a graph and saying, okay, if it's low risk, you don't suppress. If it's intermediate, you could do a mild suppression. If they're high risk thyroid cancers, you do suppress. And we're going to talk about what's what. So, what are the goals of the initial treatment? We want to remove the primary tumor and all the lymph nodes involved. Radioactive iodine, if indicated, and to receive radioactive iodine, we need to have a total thyroidectomy. So hopefully that decision is made up front. We want to stage the thyroid cancer. A lot of people don't know what staging, and ask your physician, what stage am I? Because that's a way of communicating. If you move out of state, you need to know what stage you are to say, okay, I have stage 3 thyroid cancer, I have stage 1. And that's a way of communicating and know what type of disease you have. We want to minimize morbidity, and that's why we try to do as less as possible that takes care of the primary disease, not affecting patients' morbidity. We don't want to have any patient with hoarse voice or hypoparathyroidism and hypocalcemia for life. Those are heart conditions, and a lot of people know how is living with that every day. We want to lower the risk of recurrence. We know that thyroid cancer has a potential to recur, and almost on every patient. And we want to facilitate the long-term surveillance. And those are the main goals of the initial treatment. So this 32-year-old woman, she undergoes total thyroidectomy and a left modified neck dissection. Remember that the central neck are the lymph nodes around the thyroid gland, and we call that level 6. And on the lateral neck, we call that level 2, 3, 4. And those are, bigger operations that need more recovery and have more risk. She's found to have a 2.5 centimeter well-differentiated papillary thyrocarcinoma. And when we get the pathology report, we need to see other things about that. What is the T, which is the size of the primary tumor, which impacts on the prognosis of the patient? What is the extrathyroid extension? Was this tumor outside the thyroid gland? Microscopic extrathyroid extension or macroscopic? Was there any gross invasion into the nerve, into the muscle, into the vessels? And then the vascular invasion, it's very important because that has given us this idea this tumor started to travel through the vessels with potential of distant metastasis, maybe depending on the tumor. So 20 out of 32 of these lymph nodes had a spot of thyroid cancer. So when we see that on our pathology report, it's important that we say, okay, what's the number? What's the size? And was the metastatic spot on the lymph node outside the lymph node? That's called extranodal extension. Those are factors that add to the aggressiveness of the thyroid cancer. She had too many lymph nodes on the neck. She had an intermediate risk tumor, and we decided to give her radioactive iodine, 100 milligrams of iodine 131, and the whole body scan showed uptake on the neck only. every patient that gets radioactive iodine after thyroid cancer surgery has uptake on the neck. That is normal. We want to see if there's uptake on the lateral neck or on distant sites. So the latest staging edition is the 8th edition. And this tells us about mortality of thyroid cancer. Because this is a cancer that typically has a low mortality, it's not all what we need for thyroid cancer. So the new cutoff age is 55. The 7th edition, the cutoff age was 45. And on patients that are less than 55, there are only 2 stages. One, which is localized to the neck, either intra or extrathyroidal, and stage 2 is distant metastatic disease. But if you see the expected 10-year survival rate is very high for both groups. Now, when patients are diagnosed over 55-year-olds, then we have the 4 stages. And the stage 1 is less than 4 centimeter tumor, but it's confined to the thyroid gland. It's an intrathyroidal tumor. And that makes a stage 1 with 98 to 100% mortality, survival. Stage 2 are tumors that are more than 4 centimeter, but had some sort of central or lateral lymph node invasion. They also have gross extrathyroidal extension into the strap muscles. The survival is also very high. The micro extrathyroidal extension, it's eliminated to be a higher risk factor, and now it's in the lower risk group. Stage 3, it's tumors of any size, but that have gross invasion into the surrounding structures. They could invade the larynx, the trachea, the recurrent laryngeal nerve, the subcutaneous tissue, and those have an expected 10-year survival of 60 to 70%. And stage 4 are tumors that have any size, any lymph node status, gross extrathyroidal extension, and distant metastatic disease. And this is the group that has the lower survival at 10 years. So what are the factors that we use to predict outcomes on a patient? Age, we saw that. Younger has better prognosis. Older has less of a better prognosis. What is the op report saying? What is the invasion? What is the size of the tumor? Did it take lymph nodes? Did it go invaded the recurrent laryngeal? Is the patient already hoarse from having a paralyzed vocal cord before surgery? And then what is the spread of the cancer outside the neck? Those are all the factors that we consider when we see a patient at the first visit post-op and we decide, okay, this is the prognosis that we have so far. So the American Thyroid Association guidelines came with different risk groups in terms of recurrence. And a low risk of recurrence, and this group has a chance of recur about less than 5%, are tumors that are classical papillary thyrocarcinomas, no local or distant metastatic disease, the resection was complete, no vascular invasion, and if given, no radioactive iodine is seen outside the thyroid bed. The thyroid bed is that area where the thyroid used to lie in the neck. Intermediate risk patients are the ones who have cervical lymph node metastases. They could be more aggressive. You know, it could be a tall cell variant. It could be a modular variant, a cribriform variant, and they do have vascular invasion. And then higher risk of recurrence, and that group, it's about 20% of risk of recurrence. The higher risk, and we go up to 30 to 40% risk of recurrence, is macroscopic gross extrathyroidal extension. The surgeon tells you, you know, I tried, but there's a lot of tumor left behind. I couldn't resect everything. There are distant metastatic disease, and there's inappropriate thyroglobulin elevation. Remember, we're going to talk about the thyroglobulin, but it's a tumor marker that guides us a lot on the follow-up course. So recurrence, I put that in quotations because we actually I always think this is persistent disease. Even if it comes back 10 years later, there's gotta be a cell that stayed on the neck and started to grow. Once the tumor is removed, then it's very hard to develop new spots unless there were some microscopic cells that were already there. Now, it's higher, the risk of recurrence if the resection was incomplete or the cervical lymph nodes were involved. And recurrence does not mean death. A lot of patients are super scared in the office and they're like, okay, this is the end, I'm done. You know, I'm gonna go through my bucket list. And I tell them there's so many things we could do about it, and especially nowadays. So what do we want today? We wanna individualize this to the patient. What matters for the patient, and this is a decision that we both take. We're trying not to impose therapies. We're giving options and we're saying, okay, this is what works for you and this is what you want. And this is what the guidelines recommend and this on my experience and then the patient may say, you know, maybe I don't want surgery now. I'm getting married next month. I don't want a scar on my neck. Can we wait? Can we know? Those are things that we discuss at the office all the time. What is the risk of having an aggressive treatment? If I start somebody on tyrosine kinase inhibitors and they're like, well, you know, I don't think I want to go through the fatigue and diarrhea that those therapies bring me. I'd rather, you know, deal with this and see what's going on. What is the risk of not doing anything? And if that patient says, okay, we're not doing anything, what are my risk of this, you know, little spot growing? And then this is an ongoing reevaluation that I do every time the patient comes to my office, and we sit again and we look at the patient and we look at the tumor markers and we look at the ultrasound and on the CT scans and we decide, can we continue to observe? Can we keep the therapy? Do we have to do this? It's a dynamic thing that we change every time the patient comes to see us. So what are the things that we typically use? And again, I model this for papillary because it's the most common, but we do physical exam, thyroglobulin and TSH. On medullary, we do calcitonin and CA, which are the two tumor markers, and a TSH, and we do the neck ultrasound. And this depends. I don't do neck ultrasounds at every visit. It all depends on what is the risk of recurrence of the patient, what is the tumor marker, and how far we are from the last treatment that the patient received. We're not doing stimulated thyroglobulins anymore or whole body iodine scan unless we're thinking we're going to treat that patient. So if I'm telling a patient, oh, I think maybe we could give you another dose of radioactive iodine, that's the time that I'm going to order a whole body scan. Is there any uptake? And I could give you another dose. But routinely for surveillance, we're not doing these things anymore. And then additional tests depending on the risk of disease. Some patients need PET scans. Some patients need MRIs, CT scans, brain MRIs. That's depending on the patient and the condition that they're going through. So what is thyroglobulin? A lot of people hear about this and they don't know. It's a protein made by the thyroid cells. So thyroglobulin is made by normal cells and thyroid cancer cells. So we call that a tumor marker, but it's not really a tumor marker. On patients who don't have a thyroid, it becomes a really reliable marker because we're not supposed to see a lot of thyroglobulin on a patient that underwent total thyroidectomy and maybe radioactive iodine. Levels are very low. And again, we are moving from this pattern of having a super suppressed undetectable thyroglobulin to which one is the patient's baseline thyroglobulin. Patients that do not receive radioactive iodine may have a thyroglobulin of 2, 3, maybe 5. That's because the surgeon left a little piece of normal thyroid gland, and we're dealing with that. Now, what is the line of the thyroglobulin over time? What is important? It's highly sensitive and specific. When patients have thyroglobulin antibodies, and there's nothing wrong about having thyroglobulin antibodies, that means that the patient probably has some sort of autoimmune thyroid disease. About 15% of patients with thyroid cancer have evidence of thyroglobulin antibodies. It's just more complicated for me to follow that patient because those antibodies interfere with the assay of the thyroglobulin. So I use different assays. I measure different things, but there's nothing wrong with having antibodies. It's just a little bit more complicated and to measure the actual level of the thyroglobulin. Most advanced thyroid cancer does not make a lot of thyroglobulin. So patients who have anaplastic thyroid cancer or poorly differentiated thyroid carcinoma tend to produce less thyroglobulin because that cell is living as being a normal cell and it's just very de-differentiated, not able to produce thyroglobulin. So sometimes using that as an only marker for disease is wrong. On patients that have advanced thyroid cancer or those aggressive histology features, I tend to use more imaging because I don't rely on my marker. So this patient, after surgery and after radioactive iodine, she has a thyroglobulin. The lowest was in 2013 at 0.5. Then in 2014, she went to 1. This is a typical pattern, slow increases on thyroglobulin. And we measure something that's called doubling time of thyroglobulin. It's available on the American Thyroid Association website. You could plug your thyroglobulin levels and your data, and it's going to tell you what's the doubling time. Usually patients that have a doubling time of less than 1 year, they're higher risk of recur. And I become more concerned and I start seeing that patient more often versus patients that have a doubling time of more than 3 years, which it's a very low pace on the rising of the thyroglobulin. But in 2018, she has a thyroglobulin of 7.8. So we're being now more cautious and see what's going on that thyroglobulin keeps being high. So most common site of thyroid cancer spread for medullary and differentiated thyroid cancer is 1, the neck, 2, the neck, 3, the neck. And I say that because I see a lot of patients that come with the $1 million workup of PET, MRI, DOTA-TATE, PET, and they don't find the disease. It's because they're missing the most important area, which is the neck. So first, you need a study done at a good center that really looks at the lymph nodes on the neck. And once you have that rule out, I would move on to the other sites. Typically, a thyroglobulin of 10 or below tends to be something on the neck. When it goes further, higher, it could be on other sites. It's a very hard statement because thyroglobulin level depends on the TSH suppression. So if a patient has a very, very suppressed TSH, the thyroglobulin is abnormally low, but if you release that TSH suppression, that thyroglobulin could come up. The other factor is how much thyroglobulin is that tumor making? Is this a good producer of thyroglobulin? So it's a marker that I have to take on that patient. And if patients compare to the other patient, it does not work. They're like, oh, mine is 0.1, but yours is 3. Who cares? Every tumor is different and every patient, because they have different pathology, different histology, different TSH suppression. So it doesn't, never compare yourself to anybody else. The second most common is lungs. A lot of patients have microscopic disease on the lungs. A chest CT scan typically shows that, and a non-contrast chest CT scan shows that. And the third most common place, it's the bones. So this is, I want to show that on the ultrasound, this is how we divide the central compartment. And again, it's complicated and it's not very intuitive. Level 1, it's submandibular, and thyroid cancer typically doesn't go to level 1. Level 6 is around the thyroid bed area. Lateral neck is 2, 3, 4. And then 5 is the posterior neck. And then 7 is the upper mediastinum. So thyroid cancer tends to metastasize first on the central neck and then goes to the lateral neck. It doesn't typically skip metastasis. It doesn't skip levels. So I would say 6 is the most common, and then 2, 3, 4, and then 7. 1 and 5 are the less common places for thyroid cancer to metastasize, although we have some patients that do have that. And typically, I show the ultrasound to every patient. I don't rely on any radiology reading. I read my own ultrasounds because I've seen things that are not right. This is a normal lymph node. It's a bean type shaped lymph node. They're almost like flat, like smushed. And they do have that bright hilum in the center that it's typically of a benign lymph node. Abnormal lymph nodes, and I'm going to show a picture, are rounded, are dark, and they don't have the central bright hilum. So this is the patient. As you see, very different than the picture that I showed before. It's rounded, it's dark. It has this flow here, which is also abnormal. So this patient had, and this is the zone 6 on the central neck. So this patient clearly has some disease on the central neck. So what do we do and what do we offer the patient at this point? She has some lymph node metastases persistent on the central neck. The thyroglobulin is rising, so probably those nodes are growing slowly. So do we do more surgery? Do we do another dose of radioactive iodine? There are less invasive techniques which are not done at every institution, but you could opt for alcohol ablation or the newest, which is radiofrequency ablation. And there's a lot of, we do that at the University of Colorado. You have to be very careful and you have to be evaluated by people who, do this in a high volume. Do we do external beam radiation therapy? Is the patient very sick to have surgery? Maybe this is a very old patient who's not going to, tolerate another surgery. Or this is another patient who's not wanting to have another dose of radioactive iodine. Do we start systemic therapy? Typically for small nodal disease, we don't, but it all depends on the patient and the preferences and the team who's taking care of the patient, or we just observe. You hear about active surveillance all the time. A lot of thyroid cancer management is active surveillance of little spots that are not growing or changing. You need to have a team who understands how to follow these things though. So I want to emphasize that if you have a low risk tumor and your thyroglobulin is 0 and your neck ultrasound has been negative, good, you could follow up anywhere probably. But if you have a more complex thyroid cancer, it never hurts to ask for another opinion at a thyroid center. You want to have a multidisciplinary approach of that and given options. And I have plenty of patients who, are coming for a second opinion once. They're from Pueblo, they're, I don't know, from Colorado Springs, and they're like, okay, I want to see what the university thinks about my case. We see them, we meet, we discuss those cases on Thursdays, but there are pathologists, radiation oncologists, endocrinologists, surgeons. We do those discussions and then we're like, okay, we agree with the treatment that you're getting or we don't. We suggest this and that. And it doesn't have to be a transfer of care. It has to be just a team that does this on a very high volume. So this is a study from my friend Eyal. He practices in Israel, and this is a very famous study that he published on JCM. And I want to show you, these are cases that have proven papillary thyrocarcinoma on the nodes, on the lymph nodes. And they were small, and they decided to observe. So the top is the case 1, then case 2, and then case 3. So the top case 1, clearly an abnormal lymph node. So it has preserved the shape, but it has these bright spots that are calcifications. So a lymph node with calcifications typically has thyroid cancer. But these were biopsy-proven papillary thyroid cancer on patients that had already undergone total thyroidectomy. 3 years later, unchanged. 5 years later, unchanged. Case 2, same. Baseline, abnormal, biopsy-proven PTC. 3 years later, same. 9 years later, same. So case 3, again, This is an abnormal lymph node. It's more rounded. It's dark. I don't see a highlight line. It's biopsy-proven PTC. 3 years later is this, and 10 years later is this. So active surveillance, it's an option when you do it at a center that they know what they're doing. So you have to be careful with that and make sure that you have a good sonographer to read your ultrasound. You have a good team behind that that knows what they're doing. You can't do this everywhere or with an endocrinologist who doesn't have experience on thyroid cancer. That's very important. So in this study, the lymph nodes that he observed, and these are the number of patients, 166, 20% grew more than 3 millimeters and 9% grew more than 5 millimeters, and the time to progression was 2 years. So only a small percentage of lymph nodes progress, and the progression is very slow. So we're not going to go from having 1 year a lymph node that measures 1 centimeter and another year that measures 4 centimeters. That's not going to happen. If that happens, then that's a different aggressive thyroid cancer. But typically, this is the pattern that happens on thyroid cancer. It's a very slow growth of a lymph node or a very slow pace of the rising thyroglobulin that gives us time to decide what to do. So as I said, that you could do chest X-ray, are less sensitive to detect, but some patients get it, and they're diagnosed with distant metastatic disease, CT scan. I don't know if you know this, but there are all those white dots are metastatic disease from thyroid cancer. Some areas on the neck are not reachable with neck ultrasound. So I order sometimes neck CT scans, because the areas that are behind the trachea or very deep are not really reached with the ultrasound. So if I don't have an explanation of a rising thyroglobulin and I do a good ultrasound with my radiologist and they don't find anything, then I may order an CT scan with contrast to see what's going on behind the trachea and if there's something that is being missed by the ultrasound. This is a PET with a lot of metastatic disease on the lungs, and this is the radioactive iron scan that a lot of people went through that dose of iron 131. So because the assessment and the evaluation is dynamic and we do this reassessment at every visit, usually we put the patient on 4 boxes. Are these excellent response to therapy, biochemical incomplete, structural incomplete, or indeterminate? So excellent, I have a thyroglobulin which is undetectable and a neck ultrasound that doesn't show me anything. So that's an excellent response to therapy. Biochemical incomplete response, I see a little bit of thyroglobulin, but I don't see anything on my imaging studies. Remember that the thyroglobulin or the calcitonin on medullary are very sensitive markers that sometimes start to rise before we see anything on the CAT scan. And the CAT scan shows us a microscopic spot and we're like, yes, it is. It is not. Very sensitive tumor markers. Structural incomplete are patients who have a positive tumor marker or a proven disease on the neck or in another area of the body that I have proven of that, a biopsy proven. And indeterminate is, I have a very low level of thyroglobulin or calcitonin. It's indeterminate. And I have maybe some lymph nodes on the neck that are also indeterminate. Or maybe I do a chest CT scan and shows a lung nodule, but I'm not really concerned about thyroid cancer or convinced that this is thyroid cancer. So I do this at every visit and I keep saying, okay, this patient keeps me in excellent response to therapy and my next follow-up is going to be in a year. But if that patient goes from a thyroglobulin of 1 to 10, then I'm going to say, okay, this is biochemical incomplete. And now I have to look, where's the disease? What's going on? What are the areas that we're going to investigate? So this is how we try to adapt our follow-ups based on the response to therapy. So, and these are out of the American Thyroid Association guidelines. So if you have excellent response to therapy, your thyroglobulin is measured yearly, and non-stimulated means that we're not raising the TSH, we're not giving thyrogen, or we're not stopping the levothyroxine to do that. We do an ultrasound every 5 years. And then we're not doing any stimulated thyroglobulin, diagnostic whole body scan, we're not doing anything else. In the terminate, then again, these patients, most of these patients do very well, and we see them every year. And the ultrasound, maybe now it's 1 to 3 years. And stimulated thyroglobulin is considered. I think the new guidelines that are being released next year are gonna say no. If I have a patient with biochemical incomplete, I tend to follow them every 6 months. 6 to 12 months is also okay. And then we do ultrasounds over also every 6 to 12 months because we see the thyroglobulin rising. We know there's some cells that are growing somewhere, we're not sure where, and we look for that in the neck first. And for somebody who has structural incomplete disease, we tend to see them more often. It depends if they're on therapy for tyrosine kinase inhibitors or not. There's a lot of patients that have micrometastatic disease distally and they don't progress, and we see them still once a year. But it all depends on how that patient changes over time. So what are the goals of follow-up, and why do we need a lifetime follow-up on thyroid cancer? Which doesn't mean that it has to be aggressive, but it has to be some sort of surveillance always. Some patients, I tell them, come in 3 months, some others in 6 months, some others in 18 months. And some others, I see them every 2 years. And some others that are 20 years out of surgery, I see them every 5 years at the Thyroid Cancer Survivorship Program. So it all depends. But we don't want people to lose care because sometimes there's a minimal chance that these could recur. So all patients with thyroid cancer need long-term surveillance. We want to identify the patients that are in remission, and we call in remission after 5 years of the initial treatment, and they don't have any risk, and they have excellent response to therapy. Those patients are in remission, or you could hear no evidence of disease also. Doesn't mean that that labels you forever. At that point, at the visit, you're in remission. And then the doctor says, okay, let's see each other in 2 years or in 1 year. And then we keep using that term. We want to be less aggressive monitoring and less TSH suppression if the patients are in remission, of course. So we do want to identify what is the clinically significant residual recurrent disease. Those patients that, you know, have that thyroglobulin that's still present, that lymph node that is indeterminate, that micrometastasis on the lungs that are stable but are there. Some patients have a bone metastasis and they're very stable. So are we going to observe, or we're going to be aggressive depending on the patient and depending on what's the assessment that you do in the office and what's the agreement that you have with the patient. Some patients want to be less aggressive. Some patients want to be more aggressive. And that's a feedback that you get to treat that patient. So in summary, the initial assessment means what is the risk of death, and that's the AJCC staging system, and what is the risk of recurrence based on the American Thyroid Association guidelines. So we need those two on every patient. And if you don't know that, you need to ask your physician, where am I? Am I excellent? Am I indeterminate? What is this long-term? And we do this dynamic ongoing risk assessment at every follow-up visit. And again, we're doing excellent biochemical, indeterminate, or structural incomplete response. And that changes at every visit. The AJCC staging and the ATA risk of recurrence does never change. Never change your staging. If you're stage 2, 4, 1, a diagnosis, that's going to be your staging. Sometimes I have stage 1 patient with later discovery of pulmonary metastasis, but the staging of the AJCC never changes. So more or less aggressive surveillance and testing depending on these ongoing evaluations. What I want you to finish with this is this is a dynamic thing. It's not static, and that's why we do a lifetime follow-up. And it doesn't mean that it has to be aggressive, but it needs to be there. So that's my last slide, and I'm happy to take any questions.
All right. Thank you. We have a number of good questions online, and I'll ask for also hands here in the room. We'll start with, do these recommendations for long-term follow-up change for those diagnosed as children?
So this is a talk mainly for adults. I do see kids with thyroid cancer in a clinic with a pediatric endocrinologist, and we do that once a month. And then I do a quarterly clinic where the pediatric endocrinologist transfer the patients to me also. So the guidelines for kids are different, but I do know that they're for life also. And we pretty much do these assessments every time they come. But the approach is a little bit different on kids.
Thank you, Dr. LaGreca. So in the original tumor, it was responsive to the RAI for 2 times, 10 years apart. In 2015, now it's lung mets and non-avid, and BRAF V600E plus TERT. Were those mutations there at the beginning, or is this something that happened over time which made it non-avid?
Well, that's a great question. Was the biopsy? Well, so thyroid cancer, it's known to acquire mutations over time. So a lot of patients have a mutation of BRAF, and then over time they acquire more mutations and then make the cancer more aggressive. At the time of the biopsy and the genetic profile, we're doing the genetic marker or molecular profile of that tumor. I'm assuming it's the primary tumor.
The one that was
BRAF
tested?
TERT.
No, it was not the primary tumor.
Right. So
it
then
was in the lung.
Exactly. So then I don't know if the primary tumor had the combination, right, or it's already the metastatic disease that has.
That was in the Stone Age when the original diagnosis, and they probably did not do that then.
Right, exactly. So sometimes what we could say with the mutation is, oh, at the time of the biopsy of that site, then yes, we're finding an aggressive thyroid cancer. And why do we do that mutation analysis? It's on patients who are close to start systemic therapy, because we want to know what are the therapies that patient would benefit based on the mutational profile. So we don't study every tumor that is low risk for now. For now, we don't do that on every patient. Now, at the same time, we're doing biopsies with molecular markers, but I'm not sure if everybody knows, but once you have a FNA of a thyroid nodule, there are categories that are read by the cytopathologists that are called indeterminate. Those indeterminate categories are sent out for further testing, and these companies end up doing the mutational profile of that thyroid nodule and see if they find mutations that could be seen in thyroid cancer. And then they give you another risk. So now we're having some patients with thyroid nodules that end up knowing that they're BRAF positive very early on. But typically, we don't do that if it's a diagnosis of in biopsy papillary thyroid carcinoma. We do the initial treatment, and then we do the surgery and the radioactive iron. Now, if I have a patient who comes to see me and the first thing was a bone fracture from a metastasis of a thyroid cancer, those are patients that I want a profile right away, because I think that patient is going to need systemic therapy pretty soon. And I want to know if I can help that patient with targeted mutational therapy, which are those therapies that target the mutation per se. So it's coming, and we're going to see, we're raising the knowledge on mutational profile more, but we do know that over time, thyroid cancer acquires more and more mutations, and at the level of an anaplastic, for example, it could be a cancer that over time acquire a lot of aggressiveness depending on the mutations.
One question from online. Please explain the role of adrenal hormone follow-up in sporadic medullary thyroid cancer.
Adrenal, you said adrenal?
It says adrenal hormone.
Okay, so I think this person is talking about medullary thyroid carcinoma. On 80% of the cases is called sporadic. That means it's not associated with any familial syndrome. In 20% of the cases, medullary thyroid cancer could be part of a familial syndrome, typically called MEN, multiple endocrine neoplasia. On those patients that have MEN, the red mutation is the one who's driving the carcinogenesis, the tumorigenesis. Some patients have pheochromocytomas, which are tumors of the adrenal glands on those cases. So typically we test for pheochromocytomas on those patients, making sure that they're not having that. So on sporadic, is it, this patient is asking for sporadic? Typically, we should not find pheochromocytomas. I think the physician who's ordering that is being overly cautious and making sure that this patient does not have a familial syndrome. But typically, the screening is done on patients with MEN or familial medullary thyroid carcinoma who are red mutation positive on the germline, not on the somatic, not on the tumor. They're genetically found to have a red mutation.
Okay. As a woman in her 70s who has had a total thyroidectomy and RAI treatment for papillary thyroid cancer, is it safe to get another COVID booster and the RSV vaccine?
Yes, it is safe. So thyroid cancer, it's not a, it doesn't affect the immune system. It's not an immunosuppressive thing. So every patient should be vaccinated according to the guidelines. Now, the patients who take systemic therapy, sometimes we're cautious and we take case by case. And most of my patients, even on systemic therapy, get the COVID boost and they're doing okay. But if there's a concern of immunosuppression, it's typically not due to the thyroid cancer.
Okay. Continuing with the online questions, when will the new guidelines be released?
I think they say next year. We're giving a thyroid cancer symposium this Thursday. It's for physicians. And it's going to be a hint of the guidelines there, but I believe it's an immense amount of work, the guidelines. Now it's going to be the guidelines for benign disease, for thyroid nodules, separated from the thyroid cancer. So it's becoming more complex, and I believe it's going to be next year.
Thank you. What are the most common sites for Hürthle cell cancer to go?
So Hürthle cell, I didn't talk about that. But Hürthle cell carcinoma used to be thought as part of the follicular thyroid cancer. Now it's known to be a different entity because it has its own mutational profile. Typically, it spreads almost like as a follicular carcinoma. Those are tumors that also invade more on a vascular fashion. So typically, it's more lungs, number one, bones, and then so on. But lungs or bones are the most common typical, sites for follicular or Hürthle cell carcinoma. These are tumors that spread via the vessel. So potentially they could go anywhere, but I'm just giving you the more common sites.
Okay, thank you. What does follow-up care look like 10 years down the road or 15 years?
So I guess it all depends going back to the individual patient, right? So a patient with low risk disease, the follow-up is one. A patient with intermediate risk is different. If you have a patient with excellent response to therapy or no evidence of disease, typically annual follow-up is very common, but it's not for everyone though. I think that's going back to the whole point of it depends on the patient.
Okay. Are there any questions in the room? No? Okay. How do antibodies impact your TG results?
So antibodies, as I said before, interfere with the test of the thyroglobulin. So if you do have antibodies, you need to have a specific test for that. I check thyroglobulin by 2 different assays. They're not given at every institution, but once in a while, and that doesn't mean that they need those antibodies checked by both assays every 6 months, but I use an assay that's called radioimmunoassay, RIA, and it's a send out, and it takes about 3 weeks to come back, and they dilute that to the level that they're trying to get rid of those antibodies, and it gives me such a cleaner level of the thyroglobulin.
Okay. So now we have a few more specific questions. I had total thyroidectomy with positive margins, no lymph nodes, multifocal, largest tumor 1.4 centimeters. Would this be low risk?
Okay, so it's a multifocal, 1.4 is the largest, no extrathecal extension?
No lymph nodes, positive margins, multifocal, largest tumor 1.4 centimeters.
It is considered a low risk tumor. Okay. So I think this person is asking about the positive margins. Positive margins, it's all dependent. I would have to look at the pathology report very carefully. The margins, if they're microscopic, they're thought to be almost like extrathecal extension. If it's microscopic ETE or extrathecal extension, it's almost like having microscopic margin. That means that the tumor was touching the border for 1 or 2 millimeters. Those tumors have low risk of recurrence. If I have a question, I usually call the pathologist and I said, how many millimeters is touching the margin? Because if they say positive margins, I need to know if that's focal or extensive. So either I call the surgeon to see if that's a difficult tumor to be removed from the thyroid area, or I call the pathologist and say exactly how many millimeters are touching. And a good pathologist usually says at the ink margin 1 or 2 millimeters, and that's considered a low risk of recurrence.
After having 100 RAI, my scan said no uptake. The doctor was very happy and said it's great news. I was wondering, does that mean that I am resistant to RAI since there was no uptake? Or could the surgeon have gotten everything as it was micro? I'm papillary and BRAF mutation.
So typically, everyone has uptake on the neck. I wonder if this person is asking about uptake elsewhere. Some occasionally, I have one patient every few years that have no uptake on the neck also. And yes, sometimes it means that the surgeon really removed the whole thing. But even microscopic cells could give you what we call a star effect or a little bit of uptake on the neck. So I don't think you can use that to say if the tumor is radioactive and refractory. That's not the typical labeling of a radioactive and refractory thyroid cancer. That probably means either had a very extensive surgery and the tumor is not giving uptake on the neck, which is an unusual thing. And I've seen that happen on very, very selected occasions. But I don't think you can use that to say, oh, I'm refractory or not.
Okay. Thank you. Let's see here. We've got 5 minutes left. Does a rising TGAB, does that
antibody?
Okay, indicate a potential recurrence, or is it only an indication for the TG assay?
That's a great question. So on patients who have antibodies, there's usually a fluctuation on the level of the antibody. Every time I measure, they could be, let's say I'm saying a patient has a level of antibody of 45, then it's 67, then it's 32. So there's that typical fluctuation. If that line is always rising and that patient has a 30, then a 60, then a 180, then that's a patient that I need to look for disease, because rising antibodies that are not just the typical fluctuation up and down, and it's a constant line going up over time, then yes, that could be a marker of making sure that that patient doesn't have any structural disease.
Okay. Anyone in the room? 33-year-old woman who had a lobectomy for 4.2 Hürthle cell tumor, less than 4 vessels of invasion. Are you comfortable following versus taking the other side?
So that's an area of debate. It's typically a low risk of recurrence tumor if there's focal vascular invasion and the tumor is intrathyroidal. So a lot of times we don't recommend completion thyroidectomy, because the only way I would do that if I'm thinking radioactive iron would benefit the patient. If not, then I would not give radioactive iron. So it's some other physicians are not very comfortable following that. And they do recommend completion and then radioactive iodine. It's a discussion that you have to have with your physician and see what is the risk of your tumor to recur, and you are okay with that, not having a completion and radioactive iodine versus observing.
Okay. She actually added some additional information that I didn't see right away. No lymph nodes fully encapsulated, no extra thyroidal extension.
Yeah.
Does that?
Yeah. So
okay.
so it's a low risk tumor.
Okay.
If the invasion of the vessels is focal.
Okay, great. My son had total thyroidectomy 10 years ago, RAI treatment, thyroglobulin fluctuated, suspicious lymph nodes found on ultrasound a year ago. Biopsy did not show malignancy. June 2023 PET scan showed nodules in lungs. Repeat ultrasound done 2 weeks. Nodules look stable. TSH and antibodies normal. Oncologist, lung specialists recommend waiting 6 months for repeat PET scan. Second opinion, looking for reassurance.
Okay, it's not that in a straightforward case. The PET scan was negative, they say?
PET scan showed nodule. June PET scan showed nodules in lungs. Repeat ultrasound done 2 weeks. Nodules look stable.
I mean, I think that's a complex case. Just to give an opinion, I think I need more information. PET scans are typically give something that's called an SUV, which is the measurement of the uptake of the sugar. PET scans, usually they give you a glucose infusion, and then PET scans are good to localize disease. So they give you an infusion of glucose, sugar, and it goes to the areas that the cells are replicating fast. And then they give you an SUV measurement. The SUV measurement tells us, is this more of a benign reactive lymph node, or is this a more suspicious lung nodule? So it's a lot of information that I don't know. Thyroglobulin, I don't know if over time has remained the same. I typically don't follow patients with PET scan. I use it to localize disease. And then when I know what the disease is, I tend to go with an imaging study that is more specific, as such as CT scan or MRI. I think in the end, if she's questioning, she should look for another opinion, because she needs to be reassured. You need to know that you're doing the right thing. And if you're questioning that, then it never hurts to have a second opinion. And then you can always say, okay, my doctor is doing what everybody says, or what this team with a lot of experience is saying. So I don't think it hurts.
Okay. It is 3:30. We have 2 more questions online. Do you have time for that?
Sure, go ahead.
Okay, very quickly. If you were tested for TG antibodies and it is negative, can that change over time and a future test may show positive?
Yes, it could happen that sometimes, depending on the place where you have the antibodies, depending on the disease, you could have positive antibodies later. So a thyroglobulin is never order alone. I always order a thyroglobulin panel, which includes a thyroglobulin and a thyroglobulin antibody, and that has to be. you need to have an antibody every time you check a thyroglobulin level.
All right, and here is our final question. If you have a multifocal cancer, classic PTC and follicular variant, how often do follicular cells take over and act more aggressively than slow-growing PTC? I had a partial with negative margins and microscopic cells in one lymph node.
Okay, so this patient is saying that on the same pathology specimen, they found two types of PTC, follicular variant or classical PTC. It's common to have 2 or 3 variants of thyroid cancer on the same specimen. They typically behave very similar. Follicular variant of PTC and classical PTC, I don't think you can say, oh, this, because of these cells are more aggressive or less aggressive, or you're gonna do the follow-up differently. You just have to make sure that, again, you follow with somebody who's used to see this type